Welcome everyone to the GW Global Clinical Care Alliance webinar. We are especially delighted to welcome you today because this is the first time we have one of GW's own medical students who is presenting for us, and we couldn't be more proud or more pleased to welcome Meredith Wells, who is a fourth-year medical student at GW School of Medicine. Meredith is one of our extraordinary medical students here at GW. She has received a Fogarty Fulbright scholarship that she will be telling you about, and the work and research that came from that will be the basis of her webinar with you today. I personally had the opportunity to work with Meredith when she joined our delegation of surgeons, obstetricians, traumatologists, anesthesiologists who are the Home for Surgery at the World Health Organization annual meeting, which is held in Geneva every year. And as you can imagine, she was an extraordinary member of that wonderful team. So it gives me great pleasure, both myself and Dr. Kate Douglas, the co-founder of the GCCA, as well as John Carfagno, our very important member of this team who helped us put it all together. It gives me great pleasure to welcome you all and to turn it over to soon-to-be Dr. Meredith Wells for today's webinar. Welcome, Meredith.
Thank you so much, Dr. Rousseau. I just wanted to thank Dr. Rousseau and Dr. Douglas for having me, and John for helping to organize everything. I'm really excited to be here and share about my experiences working in global health. So I have a few slides. Perfect. Alrighty. Yes, so again, I'm Meredith. I'm a fourth year at GW, and my talk today is doing more with less, so innovation and impact in global health research. And I just kind of wanted to talk about the current landscape of global health and what it's like doing global health research right now and share my own experiences with that. So it's an honor to be here. And yeah, so to start, just wanted to take you through my table of contents, the things that I wanted to touch on today, starting with why global health matters more than ever today. And then also wanted to talk about, as Dr. Rousseau mentioned, the World Health Assembly was held in May in Geneva, and some key takeaways from that meeting with a lot of outstanding global health leaders. And then I wanted to go into my own experiences as a researcher in global health through the Fulbright Fogarty Fellowship in Public Health, which I completed this past year. And then I also want to talk about ophthalmology as kind of a discipline case study within the context of global health research. And then wanted to end with some takeaways and a call for action for people who are interested in going into global health, people interested in doing research in global health. So that's what is on the agenda today. Okay, so why global health matters. I think a lot of people who are here today may agree with several of these points, but I just wanted to reiterate some things, especially today, why global health is so important. The first thing is that diseases do not respect borders. They don't care about your nationality or political affiliation. So different global health issues like pandemics and antibiotic stewardship and antimicrobial resistance, trauma, all of these things. They don't care about all of that, and they can affect everyone in the world. So it's important for us to keep them as a priority. Additionally, clinical practices here at home are impacted by what's happening in the world. So those things are all just a part of the reality of living in the world. And so I think that's one important reason for us to care about global health. Additionally, on that point, global health is local health. In 2025, people are all over the world moving from places to places for a variety of different reasons. So paying attention to what's happening in the health landscape of the rest of the world matters to be able to practice good medicine here at home. So a lot of the things that we see that are happening around the world are also reflected here at home. So I think that's another reason why it's important to care about global health. I think it also strengthens clinical skills. So I think looking at different issues in a variety of different contexts can kind of sharpen your clinical acumen, also make you a little bit more creative when presented with different health issues. And I think the other thing that's really important about it is adaptability. It teaches, especially at the level that I am as a medical student, I'm still very much learning so many things, but I think adaptability is one of those key things that makes a really strong clinician. So I think those are a couple of reasons. And then, John, if we can go to the next slide. Some other reasons why global health matters is in regards to the workforce crisis. So we're having shortages in a lot of areas of global health. And when we have system shortages around the world, it does affect the United States as well as everywhere else. So we're kind of all in this together. And I think that leads us to looking at collaboration, international collaboration, as a really, really important piece of health equity around the world. And then I also think advocacy is missing some clinician voices. I think there's a lot of healthcare workers and a lot of community workers who are strong advocates for their communities, but I think clinicians also bring a level of credibility and interesting experiences, personal experiences from working in clinics that definitely need to be elevated in the global health space. So I think that's another reason why clinicians should also be involved in this. And then, of course, finally, I will say a moral imperative, in my opinion, to advocate for health equity around the world. So those are some reasons. And John, we can go to the next. So I also now wanted to talk about the emergence of global surgery within the context of global health. So John, if we can go to the next slide. In recent years, there's been kind of a push to prioritize global surgery. And so I wanted to specifically talk about a little bit of the history involving global surgery and where we are with it today. If we look at the WHO, of course, one of the largest organizations in the world involved in global health, it was founded in 1948 through the United Nations, and it was founded with the purpose of promoting health worldwide, especially focusing on vulnerable populations. Historically, the WHO, I think many people might be familiar, but historically it was mostly focused in infectious disease and also sanitation and also obstetrics. Those tended to be kind of the main points with the WHO in the beginning decades of it. And global surgery was never really focused on because it was considered to be really expensive and really technical and not something that was going to be sustainable to do around the world. However, recently there have been some two giants within the global health world. I think people may be familiar. Dr. Jim Kim, who was also leader of the World Bank, he kind of put out a challenge for surgeons around the world to prioritize global surgery in the global health space and to kind of take up advocacy in that space. And so Dr. Paul Farmer, also another prolific global health researcher, he also wrote about surgery being considered the neglected stepchild of global health and kind of encouraged surgeons to really prioritize it and really start to advocate for it in global spaces. So I can give that as kind of a context for where we are with this. And John, if we can go to the next. Perfect. So just giving a timeline of some of the things that I mentioned, again, kind of earlier in the 1970s to the 90s, not really discussed global surgery. Again, we were really mostly focused on infectious disease, rightfully so. There was a lot of global health issues surrounding that I think were important to address. But again, surgery was seen as way too expensive, way too specialized, not cost effective for any kind of government to implement in any way. So it was really kind of pushed aside in those conversations. And you can think about it from like a general perspective, of course, when you're looking at a lot of campaigns with infectious disease that are focused on vaccines. You can teach a lot of different people to administer vaccines. And you can administer vaccines in a lot of different places, in community centers, in schools, in clinics, and hospitals. There's a lot of different places you can do that. However, when you kind of try to translate that same line of thinking into global surgery, you run into some of the issues that were kind of discussed during this time period in terms of not everybody can perform the surgery. So you do need highly specialized and highly trained surgeons. And then on top of that, along with the surgeon, you do need a highly trained anesthesiologist. And then on top of that, you need the support staff to do all of the things that people do in an operating room, which is the final key. You cannot do a surgery in the same places that you could do something like a vaccine campaign. You can't do it in schools. You can't do it, just anywhere. You would need an operating room or at least a sterile environment to conduct surgery. So those are kind of all the barriers that people were kind of discussing earlier on in the global health space, that it's just not very sustainable and very difficult to kind of come up with really good, feasible campaigns. But people continue to push that. So in the 2000s, the conversation kept evolving that it actually could be cost effective. So looking at studies, it actually would save a lot of communities a lot of money, looking at quality of life and things like that that could be prevented with surgery. And then finally, we have the emergence of the Initiative for Emergency and Essential Surgical Care once we get to 2010. And this is kind of really pushing that dialogue internationally. And then finally, we get to 2015, where we get the Lancet Commission on Global Surgery. And that is really taking those conversations and defining what is actually needed for surgeries worldwide, also looking at obstetric care and also looking at anesthesia care. And this is kind of creating a roadmap to help integrate surgery into universal health coverage. So really, 2015, the goal was to start to implement different I guess measuring like ways to measure what the need is for global surgery around the world. And they were going to use 6 surgical indicators. And so this is going to be kind of a standardized framework to understand what the surgery needs are around the world and see if we can address those needs. So that's kind of the timeline of where we are. And John, if we can go to the next slide. Perfect. So in 2015, the WHO passed a resolution at the World Health Assembly 6815, and the purpose of it was to kind of elevate surgery and anesthesia and make it a priority. So the goals were to mobilize political and financial support for essential surgery around the world, also provide guidance to formulate and implement what are called INSOAPs, which I'll talk a little bit more about, and finally, improve collection of reliable, timely surgical data. Go to the next slide. So defining what NSOAPs are National Surgical Obstetric and Anesthesia Plans. So these are kind of nationwide health plans that usually are kind of communicated to the Minister of Health or whatever the equivalent is in a certain location, focused on surgical capacity and access in wherever the location is, whatever country they're talking about. So here we are in 2025. So we've kind of been working on prioritizing global surgery in the last 10 years. And so there's been some reflection this year and where we are with those goals that were originally presented in 2015. So I have kind of an update here from the Lancet that was published about progress that has been, I guess we're still working on maybe in the last 10 years. So unfortunately, a lot of the targets have not really been met. The targets that were kind of set up from 2015 were aiming to go through 2030. And it's been very slow, very patchy, particularly in LMIC, so low and middle income countries. We also are seeing that the need for surgery is growing. So rather than meeting the need, it's actually continuing to increase, even with all of the measures that we're working on currently. And then, of course, the pandemic was really extremely destructive to global surgery as priority. Obviously, even in the United States, we can see how surgery was affected during the pandemic. We really drew back on doing a lot of surgical cases during that time. The infrastructure really has not recovered. It is in the United States, but definitely around the world, it took a very big hit. So that, and then coupled with some loss of funding later on, we really have a lot of work to do to reach some of the targets that we originally proposed in 2015. So we can go on to the next page. Here are specifically some of those challenges that we're facing. The big one, the number one is data gaps. So there has been a really sharp decline in global reporting for the surgical indicators. As I mentioned before, there were 6 surgical indicators that were kind of included in the national surgical plans. And it's just been a little bit difficult as the priorities have been shifting in the last couple of years for different ministers of health to be able to prioritize getting that data available. Some of that is also due to the workforce. People don't have enough manpower to do all of this, especially with coming out from the pandemic and all of the priority that went to the pandemic. So it's been a little difficult to overcome that. So in the beginning, in 2015, we had 43 countries that were implementing national surgical plans. And then in the last 10 years, we've just seen it slowly decrease the number of countries that are able to keep up with the data tracking. And now we only have 19 countries that have an up-to-date national surgical plan. And a lot of that is just due to workforce shortages. Additionally, financing, drop in financing globally for surgery, a lot of it due to the pandemic. And then, of course, the United States withdrew from the WHO recently as well. So huge drops in financing and being able to prioritize it. And then finally, governance. A lot of local organizations were left to work independently and lost a lot of support from an international perspective. And so from that, we just had patchy information from different local communities that haven't been able to communicate well with some of the members of the kind of international stage of global health. So those are definitely some of the challenges that we are facing. John, we can go on to the next one. So as I mentioned before, I had the amazing opportunity to go to the World Health Assembly, which is held every year, hosted by the WHO in Geneva, Switzerland. And of course, I have to shout out Dr. Rousseau and the G4 Alliance for having me. The G4 Alliance is an organization that focuses on global development in surgery and obstetrics and trauma and anesthesia. It's a fantastic organization, a powerhouse in global surgery. So it was a pleasure to be able to go with them all to the WHA and kind of understand what global health leaders are discussing this year. So in the 10-year anniversary of the Lancet Commission on Global Surgery, a lot of brilliant clinicians, brilliant community leaders were gathered to discuss the progress over the last 10 years. That's me at the United Nations. So that's me. And then I also added a little quote here that I thought was really important. I kind of mentioned it in some of the challenges that we were facing, but if you try to do advocacy without data, it's just cheerleading by Dr. Juan Mira, great clinician out of Iowa. And I think that's summarizes a lot of the key challenges that we're facing at this time is a lack of data. So those data gaps are really a problem. You can go to the next one. So here are a number of the key voices shaping global surgery today. I just put a list of really fantastic people who I think, if you are interested in global health, if you're interested in global surgery, you should definitely know these names, including our very own Dr. Rousseau. This is her giving a talk with the G4 Alliance, a very riveting and interesting talk. So these are just a few people that I think are important. So Dr. Mina Cherian, I think all of these people, if you want to read more about them, you should definitely do a little search about the wonderful work that they're doing. So Dr. Mina Cherian has done exceptional work in global initiatives for global surgery. Dr. Masaka out of Zambia used to work with the Ministry of Health in Zambia and is just a brilliant mind in understanding development of surgical need in Africa. And then Dr. Miran Thagam, who is an OBGYN, and I apologize if I said her name incorrectly, but a phenomenal OBGYN and a product of the Paul Farmer Research Fellowship and through Harvard Medical School. So she had great perspectives on her work working in obstetrics internationally. And then Dr. Kwan, who is a neurosurgeon from Indonesia and is also the president of International College of Surgeons, gave an absolutely stunning talk about the landscape of global surgery. And then, of course, we have our own Dr. Rousseau, who is a neurosurgeon and a powerhouse leading the G4 Alliance. So I would encourage all of these people to be kind of at the top of your list of people to research and learn about if you're interested in global surgery and global health. So go to the next slide. There's me and Dr. Rousseau. So this is kind of a culmination of things that these amazing leaders in global health had to say. The NIRH is the National Institute of Health and Care Research. It's an organization based in the UK. They do global health research, and they have kind of done like a systematic review to understand where we are in the last 10 years of global surgery. So it kind of culminates a lot of the things that these brilliant speakers were talking about today. So For global surgery, there is an unmet need for surgery around the world. As I mentioned before, the need is actually growing rather than falling, which is what we would expect after 10 years of advocacy, particularly in LMICs. Um, Post-op deaths have been a major problem, and they are actually exceeding a lot of global disease burdens that we think of as being very common internationally. Post-op deaths are now exceeding those things, and increases in hospital infrastructure would prevent many of these deaths. Surgery reports health systems beyond the operating theater. So obviously surgery is interdisciplinary. Medicine generally is interdisciplinary. So strengthening surgery would also strengthen a whole lot of other areas such as diagnostics and imaging, and intensive care and critical care. So those things could also be strengthened if we strengthened surgery. And then finally, we do have to talk about the economic impact because, again, scaling up surgery would actually save a lot of communities a lot of money and lost productivity that people are experiencing from a variety of different conditions that surgical intervention could help. So that is something to include as well for people who have the ear of donors and politicians who are interested in what the economic gains are, because there is an economic gain here. And then, of course, preparedness is lagging. A lot of that is due to the pandemic. So, reinvigorating preparedness and infrastructure is another really key component for advocating for global surgery. So, those are some key takeaways from the WHA. A phenomenal experience to have gone to and had with Dr. Rousseau. So, yeah, those are some points from that. And then I also wanted to talk a little bit about myself and the work that I have done as a global health researcher. So I think a lot of the challenges that I have faced mirror a lot of things that were talked about at the WHA. So I wanted to use my own experiences as kind of a case reporter, case study in working in global health research. So as I mentioned before, I'm a fourth year at GW, and in between my third and fourth year, I had the opportunity to do a Fulbright Fogarty Fellowship, and I was based in Peru. And so just have a couple pictures of me. Obviously, we trained at the NIH, so that's me at the NIH and also with the Fogarty International Center building in Bethesda, and then a couple of my co-fellows during our orientation to do this wonderful opportunity. So I definitely like to talk a little bit more about that. So, what is a Fulbright Fogarty Fellowship in Public Health? So, Fulbright, if people are familiar, is an entity that's supported by the Department of State. And then Fogarty International Center is actually an institution of the NIH. So, it's kind of a dual supported fellowship grant. It's usually awarded to somewhere between like 7 to 12 students every year, typically students who have completed 3 years of medical school training. So there's a few of us. I think there are like 7 or 8 of us this past year. And it supports research in public health and global health in resource limited settings. So the locations for where they are, we're across Asia. We're also across sub-Saharan Africa, also in Central and South Asia, and then also in Latin America and the Caribbean. And of course, I was in Peru. So yeah, it's a little bit about that. So again, the recent challenges, I think this is important before I discuss my year, the challenges that I specifically faced, which again mirror a lot of the challenges that we were discussing at the WHA. So it's very hard to be engaged in this space and not be affected by all of the changing landscape. So in my own experience with it, the Department of State lost a lot of funding, and Fulbright was paused during this year. So that was definitely tricky for a lot of us who are supported by the Department of State. And then, of course, there were a whole lot of other different changes to the budget. So, John, if you could go to the next slide. I think a lot of people are aware, but the CDC lost a lot of money for programs that fight infectious disease, and the Office of Public Health Preparedness and Response also lost some. And then, of course, the Center for Global Health at the CDC lost some funding as well. These happen to be a lot of the things that we were talking about that definitely needed support in terms of preparedness. So definitely a hard hit for global health. And of course, I think many people are aware, but I just like to keep the numbers here that the NIH lost $3.7 billion for funding for researchers. And then, of course, the one that affects me is right underneath that is the elimination of the Fogarty International Center entirely. So we lost that throughout the course of my year as both a Fulbright and a Fogarty. Some other points there are just kind of the changing landscape of budgeting throughout global health and domestically and abroad, honestly. So some context there. So just to go over a little bit more about the NIH changes in 2025, for those of you who don't know, this is kind of how the NIH is structured. It's actually a bunch of different institutes that come together to create the NIH. I think the most famous one, kind of at the top, is the NIAID, which is the National Institute of Allergy and Infectious Disease. That one is headed by Dr. Fauci, or was headed by Dr. Fauci for many, many years. So I think that's the most well-known, but all of these institutions are run by incredible researchers and clinicians. So I highlighted, I circled in red, FIC, which is the Fogarty International Center, but there are a bunch of different institutions here. So the new structure of the NIH, there's some changes to the budget that kind of pull it down by about 40%, a little less than half. And the plan is to restructure. There are a total of 27 institutes and centers within the NIH, and they're working to actually consolidate it down to 8 institutes. So the Fogarty International Center, we did lose that one already. It's one of many that will be lost in this restructuring process coming up. So it's a little bit of the context there. And then to go on to my year, I had a really wonderful year as a Fulbright Fogarty. So I just wanted to kind of touch on some pretty cool moments. So that's me and Dr. Fauci. We had a um, I guess like an introduction or kind of a orientation. That's what I'm looking for, an orientation before we started our projects. This was held at the NIH. We got to meet with incredible researchers who were giving us advice and things like that to embark on our research project. So that's me with Dr. Fauci. You can go to the next one, John. That's me in Peru. Of course, my project was based in Peru. So that's me at Machu Picchu with my Fulbright shirt. And then that's me with Dr. Collins, who used to run the NIH and a co-fellow of mine. It's a brilliant physician. It was a great opportunity to meet him as well. That's me with a llama in Peru. And then this is me conducting some of my field work. I'll talk a little bit more about the project that I was doing throughout the year, but that's a picture of me with one of my participants during my field work. And then finally, this is with the Fulbright Commission that's based in Lima in Peru. They invited us, all who were visiting researchers and teachers and all of that, to come to Lima to kind of do a meet and greet with the commission there in Lima. So it's a great opportunity. Okay, so I'm going to talk a little bit more about my project specifically. So I did a project in ophthalmology, and I wanted to give a little context of why ophthalmology. It's a great, great discipline to use as case study in global health, especially in global surgery. When we talk about ophthalmology and the need for ophthalmology worldwide, over half of the blindness in the world is preventable or treatable. And 90% of those cases of people who have preventable or treatable blindness are in LMICs. So I have a picture of here, Dr. Lloyd Williams, for those of you who might be interested in global surgery or in ophthalmology. He is kind of a prolific global surgeon in the field of ophthalmology and is working to cure blindness. So it's very topical. There's a lot of people working in that space, and there's because of the corresponding need for it. So that's why I chose ophthalmology for my research project this year. So for my project, this past year, I did a project that was looking at like an ocular needs assessment for adult women who are over 40 years of age who had known chronic exposure to household air pollution. I did this project under the leadership of Dr. William Techley. He is a global health researcher based out at Johns Hopkins. He has been doing research in Peru for decades and has a research site down in Peru. And so I stayed at this research site to do this ocular needs assessment. He has been working with a population of women there in rural Peru to see the adverse health effects of household air pollution that is a product of traditional cooking practices in the region. So, in addition to looking at other adverse health effects, we added on an ocular needs assessment component this year. So that was my piece of the larger project, was looking at any ocular needs for this population. So, a little bit more about where I was. I included a map just to kind of orient everyone to where I was actually working. So, on the right-hand side, I have a map of Peru. So, that's the country that I was working in. I think Lima is probably the most well-known city. I was not based in Lima. I was based in a little tiny town called Puno. It's kind of in the south corner of the screen. If you guys can see it, I put a little red marker next to it. It's on a very large lake, a very famous lake called Lake Titicaca, right on the border with Bolivia, if you guys can see down there. This is kind of smack in the middle of the Andes mountain range. It's very high up in the air, so the elevation is about 12,500 feet. For context, Colorado, Denver, I believe, is like 5,000 feet. So the Mile High City is not as high as this. So definitely a very interesting environment to be working in. The altitude is very, very high, and because of that, it's very, very cold in the mountains, and there's also a lot of UV exposure, so a lot of sunlight. Um, and so to conduct these, I guess to conduct the ocular needs assessment, we were visiting different houses of participants who were already previously enrolled with my PI, Dr. Checkley. And so on the left-hand side, excuse me, you can see that there are little markers along this map. Each little pin there represents a house that we visited. And so we would drive to each of these houses and do a home visit to conduct a study on their eye health. So for a visit to conduct the eye exams, it had three different components to it. So when we arrived at the house, working with these women, the first thing we did were surveys. So I had an eye health survey that I developed, and it was kind of just taking stock of ocular health history, looking if they had any symptoms, environmental exposures that could affect the eyes, access to medication and healthcare, and then we also had a dry eye questionnaire. And then after that, we did a very classic tool for ophthalmology that I'm sure most people are familiar with, but we did the visual acuity with the kind of the big E chart, the Snellen chart. And then we also had a tumbling E chart as well. And so we would use that to see what people's visual acuity is, what vision they had. And then finally, a slit lamp exam. The slit lamp is a microscope that you can use to evaluate the health of the front of the eye. I used a portable slit lamp to take with me in the field. It was donated to me by a startup in Japan. And it works as an attachment to the phone that allowed me to do exams out in the field with this population and record those exams and then collaborate with a local ophthalmologist in Puno to understand a little bit more about the health status of the eyes. So we were looking for conditions like pterygium, cataracts, and meibomian gland dysfunction. So among other things, but that's kind of how the visit would work using these three components. So some pictures just to explain a little bit more about the context and where I was working. So on the left-hand side is a picture of me and some of my team. We have researchers from Johns Hopkins in the master's program there in global health. And then we also have researchers from Lima at Cayetano, which is a university in Lima, who are coming to help with the project as well. So these are me and a few of my team members with a very, scenic view of Puno, which is the city where I was living. In the back, you can see the city and also a little bit of the Lake Titicaca, which is where we were living and working. On the right-hand side is actually one of my participants. So I did an ocular exam on her just to get the status of her eye health. And I put this picture up there to kind of emphasize that I was working with Indigenous women in the population. And then also it was a very rural environment where we were working. So as you can see, there's not much around us. So she was leading me back to the main road so I didn't get lost. And so that's kind of how my project was. And then I also wanted to report some of my preliminary findings from the project. It was a really great project, really, really fun to go down there and do some work. But there is actually a very high need for eye health in this population. So 70% I found were experiencing eye pain or discomfort on a regular basis, so either monthly down to daily. 40% had diminished visual acuity, and 91% had really high exposures, greater than 5 hours a day of sun, which can contribute to pterygium and cataract, and did not have access to any protective measures like sunglasses. Go to the next slide. Half of my population were found to have cataracts. So a lot of people with cataracts, and then 90% of those people that we found with cataracts were unaware that they were living with cataracts at all. The 10% that were aware were not ever diagnosed by a clinician, but were told by friends or family that they thought they saw something different about their eyes. And then finally, 62% had a positive score on the dry eye questionnaire, which is called the DEQ-5. So there's definitely a lot of disease burden in this population. So those are my preliminary kind of findings that we're using to work forward. So yeah, go to the next. So some key takeaways and kind of a call to action for people who are interested in global health research or doing a similar kind of project. Collaboration is going to be one of the most important things for you in developing a project. You want to find people who have a similar mission and be able to collaborate with them. The next thing is innovation. So creativity and innovation is one of the most important parts of this. So using low-cost tools are really important, and just being creative with the technologies that you have available to you. And last, or in the next, find existing infrastructure. So people who are already working in the areas that you are trying to work in, lean on those people. Again, going back to the collaboration, they typically have access to infrastructure that you may not know about, that can really facilitate research projects. So community leaders are really important to lean on. They should be leading most of the global health research there and will help you uncover any need. And then data, as I mentioned before, if you haven't measured it, you cannot fix it. So making sure that you are able to collect robust data is really, really, really important. Then finally, or next, I guess I would say communication. Scientific communication, I think in the last years, a lot of people have understood how important it is. I would say maybe in clinical training, we don't necessarily get the same training as maybe in business schools or things like that, but I do think communicating your goals and your research as sort of a sales pitch is very, very important, and being able to communicate with people outside of your discipline is very, very important. Kind of sell your project ideas, and that I think garners a little bit more support politically and financially. And then finally, I would say advocacy is another important thing. So understanding that local realities, what's happening on the ground in different communities, should be leading the discussions within a global health or international policy forum. So I think those are some of my key takeaways here. I think a lot of my own learning and experiences and challenges mirror what's going on an international scale, on a global scale. So it's kind of using my experience as kind of a case report. So those are my lessons that I would take away from this really interesting year. So now just shameless tourism pictures for people who might be interested in Peru and learning a little bit more about it. Obviously, there's a lot of really interesting cultural aspects to working abroad as well. So I had some pictures of some very typical food. On the left, we have ceviche, which is one of the traditional Peruvian dishes. More common on the coast, but definitely something you should try. In the middle, we have some more traditional Andean food, so more in the south of Peru, which is where I was living. So this is caldo de cabeza, which is, of course, like a head stew. In this case, I believe it was a sheep's head that my interpreter is using here. I had an interpreter for some of the indigenous languages for the population that I was working with, and he loved head stew. So definitely a really interesting cuisine to try. And then finally, fresh food, or excuse me, fresh trout that was caught in the river in Lake Titicaca. That is another delicacy in the Andean region in Puno. So trucha frita. It's a great thing, usually served with rice and potatoes, really delicious. And then, John, the last thing I have here is just some more pictures. Starting at the top, there's really beautiful tourism points in Peru that I think people, if they ever have an opportunity to go down there, should check out. So that's Rainbow Mountain. Of course, there are a lot of llamas in Peru. And then I have a nice picture going to the right of Puno again and the lake. And then in the corner, I have a picture of some more of my teammates and my PI who came to visit at that time as well. And then on the bottom, again, more beautiful, beautiful landscapes of Peru where I was working, some boat rides on the lake, and then the Fulbright Commission in Peru held a Thanksgiving for all of the visiting researchers. So that's me and some other great, brilliant Fulbright scholars who are working in throughout Peru. And then, of course, more beautiful views of going on visits to see participants, and then some more images from the Fulbright Commission as well, and more of Puno. And then finally, just doing some more touristing with some friends and other researchers at Huacachina, which is kind of like a oasis nestled in the middle of the desert in Peru. So I shamelessly am adding more pictures about Peru and how lovely it is, and it's such a great place to work. So yeah, I think that is all that I have here.
Whoa.
Thank you guys for having me. If anyone has any questions,
Oh,
students
that's
who are looking
wonderful,
for
Meredith.
opportunities, please reach out.
Fantastic. Fantastic. And you have pointed out so many really important aspects of why we should care about global health beyond the moral reason that we as medical people care about everyone's health, even if you're only thinking about your own self and your own community. These kinds of experiences broaden your point of view and allow you to see things that are applicable in your own setting. So, for instance, I'm willing to bet that are few people who aren't ophthalmologists on this webinar who are familiar with pterygium. And yet, the observation that childhood exposure at high altitude to UV light causes pterygium also has been shown that it prevents the development of myopia, so that there are fundamental things that we are learning about exposure of the eyes at altitude, where most of us do not live at 2 miles high, that can help us understand and find cures for very, very common things that, in that case, myopia affects 30% of the US population.
Mhm.
That's great. I know I can see there are some questions, and Kate, you are going to help uh, moderate the questions. Please go ahead.
Yeah, thanks, Meredith. That was a fabulous presentation and really appreciate both. Number one, your vision in applying for and achieving the Fogarty Scholarship. I think that's really commendable, even as you were thinking about planning for that experience and opportunity. And then, of course, the amazing work that you were able to achieve and hopefully carry on into your career. The comments, thank you to everyone who's posted a few things. First, Dr. Ferrer did mention that there's a physician at Children's who's interested in increasing access to ophthalmologic surgery and services for children globally, Dr. Laura Cooney. So if you're not already connected with her, that would be a valuable connection. And I will show some gratitude to GCCA altogether for increasing our collective kind of connections to the global ophthalmology groups and links across GW, the MFA, and Children's, because I think that's been definitely important. Here's a question, this next question from Dr. Eileen Natuzzi about the America First Global Health Strategy. This is a tough one. And I don't know, Gail and Meredith, how we're going to answer this, but it basically says this misses the AFGHS, misses what is now the leading killer worldwide and throughout Pacific Island countries, non-communicable diseases, and the other kind of shortfalls with the American First Global Health Strategy that does fund HIV, malaria, and TB, but the missing links are dominant. Just curious. Because because I get to ask the question on behalf of Dr. Natuzzi if you all have thoughts about this or ways that we can think forward, given the changes in the funding structures and the challenges we're all facing there. Gail, I wonder if you have ideas on this.
Yeah, I do. I'm just back from 3 weeks in Fiji, not for vacation, but because with the reorganization of WHO that was forced upon them by the US withdrawal, they have dealt with it by both reducing their staff by 20%, as well as redistributing many of the staff. And some of those who were living in Geneva are now living in the 6 regional offices. So, in order to show solidarity with WHO during this difficult time, the G4 Alliance had our autumn meeting in conjunction with the Western Pacific Regional Office, so-called WIPRO. So that is based in Manila. It represents 38 countries in the Pacific Basin, but big powerhouses, China, Japan, Indonesia, big population centers, and a couple aspects of that, and both the utility and frustration of the America First plan stood out. One is that there are 38 island nations, and many of them can now deal directly with the U.S. State Department by requesting bilateral arrangements. It does show that there's a lack of knowledge of history of global health programs, because the proliferation of NGOs was done in order to have compliance and surveillance of hundreds of millions and billions of dollars that were going into global health. So now we're back to nation. And so the security of those US funds are only as good as the conscience of the leaders of those nations. So we'll see how that works out. But the other thing is that there is a distressing amount of non-communicable diseases, as this questioner mentions, going on in places where the traditional focus would have been infectious diseases. So if I cut right to the chase, Fiji, the most common operation is not related to any infectious disease at all. It's amputations of the foot and toes due to diabetes, because of the Western diet that is really pervasive throughout the world. Our questioner, Dr. Nazario, asks about non-communicable diseases, and the toll that that is taking is really important. The other thing is, it's easy for us at GW and in the center of the United States, perhaps, to not be so worried about climate change and global health. But in the Pacific Basin, 2/3 of healthcare facilities are within 500 meters of the ocean, and they're rising. And many of their lobbies already seasonally have 1 or 2 inches of standing water in them. So there's going to need to be a reality adjustment if the U.S. wants to maintain its traditional position of being a generous and caring superpower.
And then if I can add my, not very much experience, but what little experience I have, I would also add something to that. I would say that this maybe goes back to my point about communication. Framing things as being America first is important because, as I mentioned before, global health is local health. So people thinking that it doesn't matter what happens on the other side of the world is not true. So I think maybe even reframing it, because there will be an economic backlash around the world when we see populations being really hit by different disease burdens. So I think reframing it, just as Dr. Rousseau mentioned, the conscience of different leaders in the United States will change as we move forward and we have different leaders. So reframing the importance of it to kind of fit whatever their conscience is at the time is another strategy to try to get a little bit more support.
Yeah, I appreciate that. I'll just chip in a little bit. I mean, obviously, the uh, decimation of the typical types of global health funding has been impactful in so many ways. And now this reorganization that has this branding will be problematic and miss a lot of things. So it's one bit could be like the communication and considering how we communicate and prioritize is important. And I also think there's going to have to be a reorganization globally as to how projects are funded and priorities are set and how different funding structures might step in as alternatives to take over where this new reorganized slash decimated system has now been it will other things will be moving in and hopefully there might be, I think it's interesting what you said, Gail, about the kind of country to country opportunity. It's disrupted lots of power systems. And so perhaps this might be an opportunity, maybe not in the immediate future, but in the longer future to disrupt some of those power structures and create opportunities for a different type of equitable future. So we'll see what happens. But I appreciate both of those comments as well. And thanks for the question. I think it's really important as we are all figuring out how are we going to continue to work and grow in global health in what is now a different environment than where we were however many, maybe a year and a half ago. Meredith, I don't know if you're looking at Dr. Asghari's comment, which has a clinical question about percentage of pterygium or cataracts that actually cause dysfunction, but then also some important references to some of the historical context as well.
Yeah, I think that's a great question. Still going through my data. So since I've been back, I think in terms of the pterygium question, how much of it is affecting vision is it's going to take me a long time to parse out. A lot of people have a lot of overlapping conditions going on. So it's kind of hard to tease out exactly what's causing diminished vision in different populations. So still working to kind of tease that apart. But and then as for the I guess the second part is not really a question, but thank you for the comment about Dr. Farmer. I think, yeah, he has, really important point about this. So thank you for that comment.
Then here's it's a webinar question. I think Dr. Kuberman from Children's would like to comment, but I don't know if can you come off of mute? Is that an option or do we need to do a promotion thing? John, I don't know if you can help us with this one. Yes, you've been promoted. Thank you.
Oh, let's see. Am I on now?
Yeah, you're on.
Okay, yeah, it's funny. I've been listening in. Meredith, that was a great presentation. I just want to quickly introduce myself, and I have just a quick comment. By the way, I know the area very well in Puno, Titicaca, whatnot. So I'm Nate Cooper. I'm the chair of pediatrics and the chief academic officer at Children's. And I was the dean for global health at UC Davis before I came here. So I've been involved in the global health space for a long time. So a lot of what you said, Elizabeth, totally resonates. Really, very sophisticated presentation that I really enjoyed. I just want to highlight a couple of things that you said, and a couple of things I just want to further augment. So partly in my role and in the new world that in which we live, I'm in Congress every month advocating for, again, I'm a pediatric emergency person, but I advocate for pediatric research, Medicaid, pediatric care, lots of issues, but also global health issues. And one thing that you said that's super important that scientists we do not do well is storytelling. So, and storytelling in a way that makes it personal is even more powerful. I've learned this by many adventures and misadventures in Congress and seeing what works and doesn't work. So that is really important. We all live next door to Congress, and I've been doing this for a long time. I was chair of emergency medicine while being dean of global health at UC Davis, and I always, came every time I come to DC. I always make an appointment in Congress and to advocate. And storytelling is key. The other thing that as we lose the federal infrastructure around global health, we do have to rely on our private partners, and private partners have stepped up. And I know there's a lot of competition for our private partners, but we have to push and advocate. And because, as Dr. Russo so rightly said, and I say this all the time, for me, a 5-year-old in DC is no different than a 5-year-old in Bangladesh. They're both 5-year-olds and they both need our care. So, that is a message that, that I convey a lot. But the last thing I was just going to say, so you're aware, I've been working very closely with Lynn Goldman at the Milken School. We have a partnership between the Milken School and Children's. We have what we're calling a pediatric global health and environmental health initiative right now that we hope to be an institute working on with private partners to build this infrastructure to do, again, this global health is focused on children because we're children's hospital, but also environmental health because we know that is a global health issue as well. And this is it's a great partnership between we're one institution, but between our institutions, it's happening. We meet on a monthly basis. And I just want everyone to know that it's happening, and we're gonna turn it into reality, but with a more kind of creative funding than we've had to do in the past, given the new reality. So I just wanted to share that and really congratulate you for really an outstanding. By the way, I was a Fulbright scholar myself, and I remember it's such an impactful time and so important, and you conveyed it really beautifully.
Thank you so much, Dr. Cooperman. I appreciate it.
Well, thank you so much. And you're a great example of why we want to reestablish that funding for that scholarship in particular. But you're right. We are looking at this period of challenging times as a pivot to a different and hopefully more sustainable way of addressing global health challenges of all kinds.
So I think we're getting close to the top of the hour. Dr. Kubman, I will say, I was just thinking as you were speaking about this new wonderful partnership, I was thinking, wow, we don't have a next speaker aligned yet for our GCCA webinar series, but this is a call out to you and to anyone else who's here that this is a great venue for our group to really learn more about the amazing work that different people in our community are doing and to stay connected, to showcase the work and then also to brainstorm together because we are encountering these challenges together, and just ideas and examples of what people are doing to navigate this complex global health environment that we're in is both inspirational and also very proactive across our GW community. So we might reach back out to you and thank you for the idea.
Yeah, that's great, Kate. And just send, if not me, there's a lot of members of this team. And this, as you pointed out, we are one community, and it's great for all of us to be aware of what each other's doing because we want to work harmoniously, synergistically. And of course, we welcome anyone on this webinar to participate in this growing initiative to ultimately become an institute as a sidebar. But great.
Yeah, I want to just second that. I would really love to have your group, Dr. Cooperman, talk about environmental health. That's another issue where we tend to think it's a problem for those people over there.
Right.
And don't realize it's a problem now for us people here, right?
Exactly. I mean, that is, of course, the short-sighted nature of all this, because again, Dr. Russo, you pointed out really well, this is, a moral obligation we have to the world. These are the existential issues of our time between global health and environment. And even if you weren't selfish and think, oh, I don't need to deal with anything because it's a problem over there. Well, guess what? The problems over there are also the problems over here, or soon will be. So even if you're just selfish and thinking about yourself, which we are not, of course, as this group, you would do the right thing because there are no borders for environmental and global health issues, you know?
That's exactly right.
Yeah.
Well, thanks for all of that. I think we should probably wrap it up. What do you think, Gail?
Yeah, I do. And I'm just, again, so grateful to my number one partner in crime, Professor Kate Douglas, who is such a joy to work with. And it's been such a pleasure putting our small institute together. Check out our website and our quarterly, right now, our activities are quarterly webinars, as well as we have funding for so annual global health fellowships, and our three fellows for this year who are in ophthalmology, emergency medicine, and neurosurgery are on their way. But we're so excited about de-siloing the great work going on at GW and amplifying what we do and augmenting what one another does. So we welcome everyone's participation in this. Thank you to Meredith, who has shown that medical students are absolutely not only the future of medicine, they are the impatient present of our field. And we're just delighted that you're here. And John, thank you so much to you and your team who always make it a pleasure for us to put on these kind of seminars. We really appreciate you and the team behind you.
Always a pleasure. Thanks for having me.
Okay,
Awesome.
thanks
Thanks,
everybody.
everybody.
Really fun.
Congratulations, Meredith. We'll see you around soon. Take care,
Okay,
everybody.
I know.